Okay, welcome everybody. I'm Alex Mohseni. This is
Amy Schiffman.
and today is December 5th, 2025. Thank you so much, all of you, for joining us. We're really excited to talk to you today. First, a disclaimer that this is being recorded and it will be published online. So if you have a problem with that, please leave. Please mute your phones so that we don't get feedback. I mean, mute your mics. So let's start with some quick introductions. I'm Alex Mohseni. I help lead care transformation at Optum, the largest risk-bearing medical group in the US. I support a number of healthcare startups in various capacities. And I'm the founder of ClinX Academy, a program where we train physicians and help them get into physician executive roles.
I'm Amy Schiffman. I am a board certified ER doc, and so is he. He didn't say it. I am the founder of a house calls practice that I sold to a really large emergency medicine staffing company. And in that process, I became very experienced in billing and coding in the chronic care management space and the post-acute care space. I'm the former CMO of a post-acute care company that's focused on care management and hospice. And I've been the CMO and advisor to numerous companies in the device space, the MA space, the Part B space. I'm an age tech enthusiast, Go Age Tech Connect. And I'm also the founder of Aging Here, which is a consultancy and education platform for understanding the ecosystem of aging. And we are primarily focused on helping founders, mature organizations, and anyone in the senior serving space to kind of figure it all out, because it's pretty complicated.
Amy's the national expert on Medicare, so and a longtime friend. So the first quick, what are our goals today? So today, obviously, we're talking about the newly announced Medicare Access Program, and our goal today is less to talk about what is the program, which anybody can look up, and although we will cover it briefly, but more about why is everybody so excited about it. What should you know about it? And if you want to participate, what are some of the things you should start doing now? So let's start with the what. What is the Access Program? So, Amy.
Okay, so the Access Program, which is ACCE SS, is an opportunity for providers, which means people who provide care, to develop programs that use technology in the chronic disease management space and get paid outcomes, not just like checking a box and saying, "Oh, I did it," but actually outcomes.
Yeah, so I want to kind of reiterate, this is like the key thing. Prior to this program, most of original Medicare or traditional Medicare was normally just paid on volume, done mostly by humans, right? And now Medicare is saying, or CMMI is saying, now we'll pay based on outcomes, potentially done mostly by technology. So this is very different on two different dimensions here. Who's doing the work, and work based on what sort of work, whether it's just the units of doing work versus the outcomes from the work.
Right, and they've given this concept, this outcome-based payment system, a new word, like a new acronym. It's called OAP, which is Outcomes Aligned Payments. And we don't have a lot of information about this, though.
Right.
We don't really know what this actually looks like. There was, we were on this lovely meeting yesterday that I was directly from CMMI, and it did not have a ton of information about what that means in terms of money flow. But it's clear that this is where it's going to be, is the OAP.
Right. So we don't know yet is this going to be some sort of PMPM based model or what. So, and we don't know what the numbers yet. So there's still a lot that needs to be clarified. A lot of folks were hoping for more clarification yesterday. There really wasn't that much that came out. But we do know that, again, it's going to be based on outcomes. The outcomes are potentially some based on improvement in the clinical measure and some based on just controlling the clinical measures and not letting it get worse.
So wait, as an example, that might mean we just don't want somebody's blood pressure to go up. We don't necessarily need to see it go down, but it could, as long as it's staying the same, because people, traditionally, if they're not doing well, their blood pressure goes up. So they're looking for stability or improvement.
Okay. There's 4 clinical that Medicare has announced will be the initial 4 tracks for this 10-year-long pilot program. They did say that there's potentially additional tracks that will be added beyond that. So Amy, do you want to cover what those tracks are?
Sure. So the first is the early cardiometabolic conditions. That's like hypertension, dyslipidemia, obesity, and prediabetes. There's another track, which is sort of like it got worse, which is the cardio-kidney metabolic conditions, which is worsening of diabetes, CKD, which is chronic kidney disease, and atherosclerotic cardiovascular disease.
The next two tracks are the musculoskeletal chronic pain track and the behavioral health, depression, and anxiety track. So those 4 tracks are the only ones that are initially going to be covered.
Okay, so I think the key elements of these 4 tracks is that they're looking to create companies, or they're looking to spur innovation, which will then create entrepreneurship for companies that are in the technology-based intervention space. That's devices or software.
Yeah, although you don't have to. Like, if you wanted to do this purely with humans, like, you could do that.
Well, that would sound awful. Okay, yeah, I mean, I think you're trying to get technology up and going, and I think it's a very technology-focused presentation, to be honest with you. So it's technology-based interventions, either devices or software or combinations thereof, that will keep people either stable or improve outcomes.
Yeah, so we got a comment, slides. No, we didn't create slides. We don't like slides.
We're just chatty chat.
We'd rather see your pretty faces.
And you ours.
Yeah, but we'll send our notes out to everybody. We have all your emails, so we'll send your notes out.
Yeah.
Our notes out. Okay, so the next key point. So one key kind of element is that technology is okay to use, which prior to this program, the CMS had only dipped its toe in technology with RPM and a few other programs. Number 2, they specifically called out that asynchronous engagement is okay. So again, this is unusual for CMS to say that it doesn't have to be a live encounter with a human.
But wait, time out. That's really important, because what is that kind of saying out loud?
Right.
Like, who has to be on the other end of that asynchronous communication?
Yeah, so what this is really doing is it's creating a mechanism by which we can start getting AI reimbursed in healthcare, right? Because asynchronous communication oftentimes is asynchronous text, and text can be generated by AI-based solutions that are, supervised and monitored by physicians. So without them explicitly saying this, I think this is really trying to accelerate our path to getting AI into the healthcare ecosystem.
I know you don't love it when I'm super chatty, but I have to say this.
Yeah.
So, and by the way, we have a podcast together in case you haven't noticed that. Anyway, but the long and the short of it is, if somebody is out in the non-Medicare space, they are often dealing with AI chatbots all the time, agentic AI. And every single time somebody would come to me with a pitch deck that had AI embedded in it and then said, hey, is Medicare going to pay because there's AI? And I was like, no, there's no CPT code for that.
Right.
So if there's no CPT code for it, there was no payment mechanism in the past. So this is kind of like opening up that space from what we can gather for the, and like bringing AI into it and then having that actually be part of a payment model.
So the other thing that was really interesting here was, as many of you know, even software can be considered a medical device that has to go through an FDA approval process if you want to use it. And so what the FDA announced and reiterated yesterday in the live stream event is that specifically for the access model, FDA will potentially, I'm going to read exactly what it says. The FDA can exercise its enforcement discretion and not enforce certain applicable requirements, such as pre-market authorization requirements, when their device is offered to or by the CMMI access participants. So this is really, really interesting. They're basically trying to create a fast path to getting devices and potentially software as a device approved for this program. And then in the fine print, they did say the FDA plans to select up to 10 manufacturers in each of the 4 specific clinical use case areas to participate in the pilot. So it's not a free-for-all, but this is like an unbelievable relaxation of the typical barriers that are needed to get a new solution out to market.
Right, and I think the key here is that when when all of these things happen, right, it's spurring interest throughout the entire healthcare ecosystem of how to innovate. But it is clear that they are trying to start this out with a smaller subset of people, maybe people that are already established.
The other key element they announced is that in addition to the participating organizations who actually have to apply to participate in this program, the referring physicians, like primary care physicians who refer patients into this sort of program, they too can bill for their participation in the program as a referring physician and receiving the output from these programs in the tune of about $100 per year, which is not a lot of money, but it's a little something.
Right, and I do want to add that this is not an unusual technique within the Medicare fee-for-service space. There are other models that actually sort of encourage physicians to refer, let's say, to Part A home health, because there's so much evidence that that referral actually keeps people out of the emergency room. So they're actually rewarding the physician for either care plan oversight or for referring to another Medicare entity. And I think so that's an interesting model.
Yeah. Although if you read what some folks have said, a lot of folks have said this $100 is way insufficient. But on the other hand, if I am a referring physician, and okay, let's just say they're going to encourage me, I'm going to get $100 over some period of time, I can also bill for chronic care management time for them managing the incoming data from that access program. Like it is going to be a bi-directional. I refer and then they give us data. Yeah. Okay. So now let's get to the requirements of this program. So if you want to, let's say you want to start a company, you're a part of an existing company, and you want to get into this, what's everything you need to do and by when? So Amy, do you want to start?
Okay, sure. So the first thing is you have to be a Part B provider, which essentially means you have to either be a physician with a PC, which has a relationship with Medicare, or you have to be an entity that, and this is where Alex is a specialist, is if you are a company that is not owned or operated by a physician, you would have to enter into a PC MSO model that is basically exactly what Alex sort of does in his spare time. And then you would enroll in Medicare. And by saying all of that, I just added 6 months to your life in terms of what you have to do, because becoming a PC owner and then having a PC MSO model, whatever, it's a lot of corporate, I always say gobbledygook and lawyer stuff. But basically you have to apply to Medicare.
How long does that usually take?
So in general, if you are starting from scratch, between 3 and 6 months.
Yeah, and so the applications are due April 1st if you want to be live by July 1st. Now, on another page, CMS did also say March 20th, the applications are due if you want to be live by July 1st. So there's a little discrepancy in what they've published. But so that's what, about 100 days from now. That's not a lot of time.
I mean,
maybe a little bit more than 100 days.
It seems like they're kind of benefiting people who may already be set up in the system. They don't want to, they're sort of saying, all right, let's get people who are not going to sort of like be stuck on just starting a company.
Right. So
starting a practice.
Okay. So in order to be a Part B provider,
you need an NPI number.
Yep.
You need to have an application in there. You need to have also, you have to basically apply to Medicare, go through their development process. And you also have to be what's known as a covered entity in order to participate in this program, which essentially means that you have the ability to bill electronically.
Right. So you
have to be a company. You have med mal insurance, you have to have bank accounts, and most importantly, and I think this is sort of like where a lot of this particular webinar that we're doing right now is focused, is you need to have a physician clinical director.
Yeah, so they've specifically mentioned that all of the participating organizations must have a physician clinical director. I've never actually seen a rule like this, that they specifically, well, I guess there's a couple places, maybe in the hospice and a few.
Well, yes, but I think this is about lessons learned. I mean, I think if you start looking at a lot of tech companies that sort of popped up out of the blue, the last thing they looked for was a CMO or a physician advisor. And they'd be like, what do you mean? Like, this all makes sense based on all the, studies that I did and all of the pro formas that I made, but the clinical input was often sort of put to the last part of their, So I would argue that this right here is about lessons learned.
Yeah, I like it. Additionally, the other requirements are that you have to be able to send data, your outcomes data, to CMS via API, which is really interesting because they're going to create a leaderboard. They've already essentially announced that there's going to be a leaderboard of every participating organization, and their relative performance, risk adjusted by each clinical track. So I think that's super interesting. There's obviously been already some potential criticisms of how that might be done, whether it's based on an intention to treat basis or not, which, depending on how it is or not, may allow for all sorts of gamesmanship of that number, as you can imagine.
But this whole thing is actually capitalism at its best, right? I mean,
Well, if it's done properly, and I appreciate, I don't know if Graham Walker is on the call today, but he really pointed out this potential gamesmanship here, so kudos to him. And
it's
then,
like a Peloton leaderboard.
there's some folks that are definitely cheating. That's for sure. That's impossible. Yeah. Okay. Then also, these participating organizations must collaborate with the referring physician. So, and that can be harder than it seems. So, okay. So let's get to this idea of like, why is there so much excitement? I thought we were going to get like 8 people on this call, and we have like many more than that. So why is everybody talking about this?
Okay, I think I want to take this
Yeah.
one. Okay, so it turns out that Medicare Part B, which is based on CPT and ICD-10 coding and then matching those two things up, is a very limiting, non-innovative space.
Yeah.
Essentially, unless you can match an innovation to an actual CPT code, that innovation kind of like has nowhere to go, and it's like where fun goes to die. So this idea of innovating within the Part B space is actually really interesting. And so basically, like, think about this. We get sent decks all the time, and people say, oh, I every doctor is going to want to give this to their patient, and every patient's going to want this. But then you go, who's going to pay for this?
Right.
And they go, well, doesn't Medicare pay for this stuff? And I go, not unless it's got a CPT code.
Right.
So I think this is an opportunity for med tech, health tech, digital tech, age tech, whatever it's going to be, to potentially have a new home with either not necessarily a CPT code, but it'll probably get a CPT code, and it'll have some sort of structure to it. So unless there was a payment mechanism, Part B was where good ideas went to die.
Yeah, and I want to add on, there's a bunch of folks on the call here who have significant experience with solutions in the value-based care space. We have Phil Mitchell here, formerly from Dispatch Health. We have Reza Alavi here, who works with a bunch of startups. And all of those folks can tell you that one of the biggest challenges, if you're a new solution in trying to sell a value-based care solution to risk-bearing entities, the first question all the buyers, which is the payers, the risk-bearing entities, are going to ask you is, show me your outcomes data, right? And so you have a chicken and egg problem. Well, how do you generate outcomes data if it takes 18 months just to get your first deal? Right? So then a lot of companies have to start in a fee-for-service model just to start generating some revenue and start generating some data. But the problem is, if you build your company on fee-for-service rails to try to move those rails over to a value-based care model later, it doesn't really translate well. Like it's rarely done well. It's very difficult. So this allows for a mechanism for value-based care, meaning anybody who wants to just build something that solves a problem to start generating revenue and data from day one, which is unbelievable. I think it's amazing.
And I want to add something to what you just said, which I think is really important, which is this sort of like translational idea where you go from fee-for-service Medicare to value-based space. Fee-for-service Medicare pays for inefficiency. Time-based coding is essentially the key to inefficiency. Oh, sure, I'll just sit here and just talk about the weather with the patient and see how I can make it apply to their health. It doesn't translate when you're looking at a value-based product, which is looking for doing more with less.
Yeah. Okay. The other reasons I think that folks are really excited about this, one is that CMMI has explicitly called out that they are basically enacting this CMMI safe harbor to allow for the waiving of copays. And this might seem, all Part B, services, with a few exceptions, have a 20% beneficiary copay. It might not seem like a big deal, but that copay, as I kind of talk to folks, is not only a financial barrier to the patient, but it's also a mindset barrier to the referring physician. Because referring docs don't like to be like, they're not salesmen. They don't like to be salesmen. And if they're trying to get their patient to do something and they know the patient has to pay out of pocket for that, it's really difficult for a lot of doctors to do that, and rightfully so. And so by removing that barrier, we're really reducing the friction to getting folks to try this.
Yeah, I want to add to that. I think it's actually really interesting because what happens is in traditional Medicare, for those of you who are not entirely, clear on this, there is an 80-20 split between, like, if Medicare has a fixed Medicare allowable cost, Medicare themselves is only going to pay 80% of that. And then the sort of cost sharing for the patient is 20%. Now, most people get these Medigap policies, which in general pay for that other 20%. But imagine a scenario, and this is sort of like typical for healthcare, is that basically imagine you do all this work, you tell the patient that, it's probable that your Medigap policy will pay the additional 20%, but there may be something inside of all of there that says, oh, we're not going to pay that other 20% if it was done by a nurse practitioner or a PA or every third Thursday or whatever it might be, because insurance companies make money by not paying for stuff. So I think it's important to understand that physicians do actually have patients that have Medigap policies that don't pay everything. And so there is potentially going to be cost sharing, or there's patients that don't in fact have that. So it's a risk on all sides. So when you have that discussion as a provider and then you have to consent people, it is actually, you feel bad saying, oh, like, I really want to give you RPM and give you a blood pressure cuff in your home, but guess what? It may actually cost you $40 a month. I just don't know.
Well, and the people who probably need this sort of stuff the most
are not the ones who are going to pay. They would literally forego.
And they're the ones who don't have Medigap, probably, right? Potentially,
yeah. Or they
don't
have great Medigap. Or the problem is that you're basically saying to the patient, I don't know if your Medigap policy is going to pay for this. That's the key, is that you don't know.
So the other thing that I think has generated a lot of excitement is this whole leaderboard concept of like really publishing everybody who's participating, how are they doing? I hope that the data is relatively fresh, because if it's like other CMS quality stuff where it's like, I don't know, 12 to 18 months old, I think that's just way less exciting. So I hope to see some innovation on how quickly we can get data, clean it, and publish it.
I want to just add in how incredibly different this is from the current RPM and RTM models.
Right.
Where literally you're just sort of like, hey, just go over here, and then somehow you'll make an additional $50 to $100 per member per month, or per patient per month. This is truly a value.
Yeah. Dr. Alavi, what's going on? Question.
You mentioned RPM and RTM and so on. Can you kind of talk about the unit economics of some of these things? So if there is a G code or something that they're going to pay X amount, let's say $50, $60, and so on, the human-led solutions versus software-led solutions, right? This is going to really put pressure on, getting tech solutions over human capital, right?
Yeah. I mean, so, RPM can generally reimburse in the fee-for-service space $100 to $150 a month, depending on how many units of the monitoring and the readings and all that you did.
But what's the net for the provider in general?
Probably less than 50% of that, because you got to pay the vendor that's actually helping you do all of that.
Yeah.
I think when I think about margins, I think there's two components to the margin, right? What is the revenue versus what is the cost, right? So I think the revenue here is probably going to be less, I would guess, than the revenue might be in a pure fee-for-service model, but your cost basis is potentially way smaller than the revenue might be. And the reason is because they're specifically calling out that you could use asynchronous technology, your potential unit cost could be in the pennies versus being in the tens of dollars per unit of engagement per patient per month.
Riz, I want to add a little bit to what you just said also. If you think about other CMMI models, like the guide model and what was the early case of CCM and all of that, the idea here is that they would sort of get rid of some of the administrivia of like individually coding line by line and then sending in literally the Medicare CMS, like a CMS 1500 form for every little single like thing that you do. I mean, if you can say, well, look, I have to hire an $80,000 a year employee in order to keep track of all of these codes. Now you don't have to have that person, and you just kind of are like, all right, I'm just going to be all in, and like maybe I'm not going to get the same unit economics per patient as if I like surgically inserted my code stack with like 7 CPT codes. Like that actually in and of itself is probably worth it.
You mentioned guide. What do you think about client acquisition, patient acquisition cost, and
Is he reading ahead?
Yeah. So
we have
actually,
not organized this before. We happen to be friends, but we have not like reviewed
no, so
any of the
actually, so our
questions.
next
Sorry.
whole section is all of the challenges of this program. So we're going to
So
touch on
can you
that.
mute him? I'm
No,
sorry.
no. So before we do that, I want to mention one last thing on the excitement level. So during yesterday's CMS event, they did announce that I believe more than 400 companies already in the first 72 hours had Phil says nobody can mute Reza. Yeah, more than 400 companies had already submitted their interest application to CMS for that. The formal application to apply has not yet been released. Okay, so to get to what Reza's leading us to, which is there's actually still a lot of challenges. As exciting as this is, there are a lot of potential challenges. And if you're a physician or you're a founder or you want to get involved in this, you should go in eyes wide open. So Amy, start us off.
Okay, so I think some of the early anticipated challenges are as basic as you got to set up your organization. You need a PC, you need a PC MSO model, you got to get your Medicare application, you've got to get a bank account, you got to be real. You have to identify your physician, the physician opportunity is going to be out there. So you have to get all of your players in place if you want to be participating in the August application.
July.
But you have to apply in
You mean
April application
Yeah.
for the July start.
Yeah.
Yes.
And what makes this like really crazy is a lot of the rules have not yet been published. We don't even know what the reimbursement is going to be. So how do you
how do you even know how much money you have to like get for capital or anything like that?
So there's definitely like a difficult moment right now where there's just insufficient information to do everything you need to do. I think, but already folks should start thinking about like who do they want to be their physician clinical director, right, as is the requirement. And ideally you want a physician who can actually help you not only supervise this, but actually build out like what is our clinical model, why is it this way, and translate all of the clinical needs across the different business domains, you know, whether it's the data folks, the technology, the automation folks, the security folks, etc.
Well, so you need somebody who actually understands the business model. So you can't just take some guy who's been a hospitalist and be like, plug him in just because he's like a name on a list.
Right.
Yeah.
Next big challenge is what Reza brought up, which is patient recruitment. Patient recruitment, I would say of all the barriers to these companies actually succeeding, it's probably in the top 3. I mean, this is like one of the #1 reasons I see startups in this space fail. It's way, way harder than people realize.
Yeah, I mean, I will just, I'm not trying to pick on the guide program specifically or PACE specifically, but any innovation, it requires so much thinking about how do you can have the best idea in the world here, but unless you create a gravitational force with that particular product, for some reason, it's got to be solving a problem. And how you sell that is so important. And physicians don't change their workflows easily.
Yeah. Other barriers, all of this is going to require significant capital. $100 a year to the referring physician is probably insufficient. For a lot of physicians, that's not enough. Running a medical practice in and of itself with managing all the infrastructure, the revenue cycle stuff, like it's a nightmare. Okay, this one, go.
Okay,
Amy.
so basically the key to not knowing about all of this is this going to disincentivize people from doing other types of things? We don't know that if you refer someone to an access program, can you still bill CCM? If you refer somebody to an access program, can you still do principal illness navigation, another new code? So we don't have a lot of information about the interference of all of these codes. This is the Part B space at its finest.
So other barriers, I mean, the healthcare system it's fragmented, interoperability is still broken. They mentioned some innovations about interoperability yesterday, but we're still nowhere where we need to be. Cognitive load of everybody, including referring physicians,
Which will ultimately impact referrals.
Yeah, is a huge barrier. So no matter how much you increase that dollar amount that you give to the referring doc, they're beyond capacity, many of them, and they can't take any new programs. Change management, again, is super difficult.
Yeah, I mean, I think that there's a deep culture shift that has to happen in any organization. Just think about what it is to roll out an EMR.
Yeah.
You know, think about how many stakeholders and how many meetings, you know, in front of the meetings, and then a meeting about the other meeting. I mean, the amount of cultural change that has to happen both internally to a referring organization or just from a societal perspective for doctors to realize that technology is now the new thing. And that doesn't even include the patients themselves, which brings up the major issue of digital literacy.
Yeah, so you're the expert on
Okay, so basically, we all talk about digital literacy. It is a social determinant of health, digital literacy. So this is like a thing that impacts people's ability to take care of themselves. It impacts whether or not they can get into the portal and can get their own medical information. We know people actually make trips back to the emergency department because they can't even log into their portal. So this is lagging. It's kind of funny that Medicare has chosen to be the insurer of choice to roll out this like high-tech solution, because it's not exactly like this is the most digitally literate group of people.
Right.
These are not digitally native folks, and app developers are very much used to developing things for digital natives. I mean, we're not far, right? Like we got to have like maybe 10 more years before everybody that's 65 has been like, I got a smartphone.
Yeah.
But yeah, that's important.
I think that's a huge one, and people always underestimate how difficult it is to get these seniors to use whatever technology solution.
I mean, and by the way, one of the things I think is important is a physician practice doesn't want to become a help desk.
Yeah.
For any of these products.
Okay, other challenges, attribution, I think, is potentially going to be messy. Patients can be participating in multiple different access programs. So we don't know yet how attribution is going to work. We don't really know how the risk adjustment is going to work. These programs, because they're involving management of chronic disease, you're going to have to do not only coordinate with the primary care or the referring physician, but also with caregivers and family, and that's not easy.
In every ologist they have potentially.
Yeah. I think another big challenge for anybody doing chronic disease management is scope creep, right? So you start providing X service to the patient, and the patient says, well, can you also do Y for me? And if you say no, they say, then who in the world are you then? Why are you involved in my care if you can't do everything for me? And where's the line drawn between you and my PCP? And that creates a lot of potential challenges.
I think, you know, with anything that's going to be happening, let's just say I am become the referring practice. That's going to require a lot of project management. I think that the input on the referring physician side may be far more impactful than anybody really thinks.
Another interesting, very minor thing that it was mentioned barely, but I think is actually critically important, is that it's not just outcomes that matter in terms of clinical outcomes, which is where the focus has been, but the outcomes must translate into savings if we want this program to continue. So CMS said, yeah, we're going to measure all the outcomes, but then we're going to do our own actuarial analysis and see are there actual financial savings? And if they're not, this program is probably not going to continue, at least not in its current model, or current fashion.
Well, also, and they're going to probably have points at which you're like, what is the change, the actual change that made a difference too? And that's also going to be really hard to pull apart from a multivariate perspective.
100%. Okay, so a lot of you here are physicians. You're potentially interested in getting involved. This program requires clinical oversight by a physician. So we want to talk about, like, what does that mean? What should you be thinking about if you're potentially interested in that?
One of the fun things that Alex and I did is after the webinar yesterday, we sat down and said, what would be the skill set required for a physician to be the overseeing physician for an access company? So we just started throwing stuff out. We were just brainstorming.
Yeah. So obviously, like, I think table stakes is like the clinical knowledge that you have, like, okay, that's fine. But what about everything else, right? So I think one, just understanding Medicare, its structure, especially Part B Medicare.
Right.
I think you have to understand that. And, you know,
yeah.
This is the lady who's taught me everything.
So, I mean, I think the key is really saying you have to like be able to kind of like have some white labeled numbers in your head. So at all times, you need to be able to know how many people are in Medicare, what percentage are in like, you know, Part B this, and how many are in MA, and all those different sort of like subcategories of all the different types of Medicare. You want to know how many people fit into all that, because that will help drive your pro forma. And as a physician on a team, you'll probably be in the C-suite and you're going to be driving revenue with them. And so you need to be able to speak their language.
And I think you got to know the rules. Right?
Well, you got to know the rules.
Know how the money moves and why the money moves the way.
Yeah, you have to have a perspective on RCM. You don't want to pluck some guy who's never ever understood how in their hospitalist job they ended up with a paycheck of $180,000 a year. You want to know somebody who's actually gone behind the little velvet thing there and said, oh my God, how does that work? Can someone show me how we get paid?
Yeah, I think you should also have a basic understanding of other VBC models, whether it's, you know, Medicare Advantage, ACOs, MSSP. Like, you got to know a little bit about the ecosystem.
Absolutely. And I think you have to know about the legacy care management codes, even though I'm calling them legacy as if they're like, they're going to sunset and be in some sort of museum somewhere. But I mean, they are already out there, and this looks to be like something that could potentially replace them. So you have to be somebody who can speak that language: RPM, RTM, CCM, PCM, PIN, CHI, all these different crazy codes. You need to be able to understand what they were trying to accomplish and how that would work vis-a-vis the new program.
And because this is very much likely going to be technology heavy, I think you got to have a basic understanding of the EHR options, interoperability, HIEs, connecting with these various sources, requirements to share back information. Like, you got to know the basics around that.
Yeah, and I think understanding what types of quality measures. I mean, this is not like MIPS. This is not like all like gap closure and MA, but maybe it is because we don't have a lot of information. But you have to understand that those are concepts that you should be asking about as we move forward. You have to know the questions to ask.
Reza.
Sorry to jump in all the time. You mentioned ACOs. I think ACO Reach and MSSP knowledge is going to be key. There's a lot of third-party enablers that love digital solutions and have not had a way to pay for them, right? Because they share the kind of the cost and benefits across three parties. But this way, they could perhaps be a referral source and not have to pay for anything. And my understanding is the first year or two, these don't count against their ACO total cost of care. So knowledge of those things, going to these ACO meetings, developing those relationships in the next 6 months are also going to be super key.
Yeah, Reza's indirectly inviting you to one of his events at NACOS. Yeah, no, 100%. You have to understand how the incentives are modeled with these various risk-bearing and value-based care models. And then understand how does the access program fit or not fit or affect the calculations that are being done. 100%. I think all physicians involved in this program need to have a relatively strong understanding of the various laws and regulations, especially as it relates to things like what's allowed and what's not allowed in terms of referrals, patient incentives, things like that.
Having an MD unto itself means absolutely nothing. You have to have a very high level of knowledge outside of medicine in order to probably be a good participant in the C-suite for one of these access companies.
Yeah.
Okay, so whoever comes on board as a physician, sort of supervisor in this has got to be able to also not just talk about the tech, and you have to have some, talk about APIs and be all cool like that, but you also have to be able to interact with the C-suite, and you're going to be able to bring, not only bringing clinical perspective, but you are bringing sort of a connectivity from a soft skill perspective to a lot of these organizations as well. Because many of them are going to be a bunch of tech guys who have very little experience in healthcare, but they knew how to make money in fintech, famtech, whatever tech, all the other techs. How hard is health tech? I mean, how hard could it possibly be? I mean, it's just like people and lives and such, but and understanding that patient acquisition curves don't look like hockey sticks in healthcare. They just don't.
Yeah. I think folks should also have an understanding of AI, automation, business tools, et cetera.
Yeah.
Basic understanding of the venture model and fundraising. as Amy said, business etiquette, communication, soft skills, all very important.
Yeah. And I think, this is our last sort of like thought about this, is that anybody who comes in that's a physician into any organization that may or may not be started by another physician or just a tech guy or a business person, you need a healthy dose of cynicism and realism. You need to be able to bring to the table some realistic speak. I mean, I hate to say this, but I've been called, this is terrible, I've been called like a baby killer. Like people will give me an idea and I'll sit down and be like, no, like that can't work. You have to have some gumption to be able to refute their presumptions and their business assumptions about how this is really going to work. Because if you see from a very far distance, no doctor is going to refer to this for that, you have to be able to call it out. So the cynicism has to exist. You don't want it to overcome you, but that is a soft skill as well.
Yeah. So in order to kind of wrap up this initial portion, and then we'll open up to Q&A, I think one of the most important messages here is if you want to be live by July 1st, you have to have your entire Part B structure set up by April 1st. And for many of you, that means you have to set up a PC MSO structure and you have to apply to Medicare. All of that is stuff that takes time to get set up. There's resources out there that can help you. I know we have Sunir here. He's co-founder of the Air Physician Academy. They do a lot of work in terms of setting up PC MSO structures, helping companies with that and finding physicians. Also through my company, ClinX, we help physicians kind of understand all of that. Amy is an expert on the whole Medicare enrollment piece, and she helps a lot of companies, not only with Medicare enrollment, but also last mile deployment of services that service seniors, which is a really, really challenging problem. So there's resources out there. And I guess we'll open it up to questions, whether you want to put them in text or just raise your hand. Who else is excited about this? Okay, Stephen Farber. Yes, sir.
How are you doing? This is great. Thanks so much. I stuck it in the messages, but is there anything in here that actually allows payments to patients and or caregivers for participation in this, or is that still not something that's being contemplated?
I'll tell you, Stephen, I think, anybody can sort of refer themselves into a lot of different programs within Medicare, and it hasn't been really clear. I would doubt in this program that there is anything that benefits caregivers specifically and directly. This is really
about tied to outcomes.
So, I mean, we know that caregivers can impact outcomes, and we know that they are a critical tool in improving people's care. But in this particular access model, no.
Okay, thanks.
At least, yeah.
I mean, like I said, like it was not announced, but it would be my guess, no, because this looks like a caregivers have to participate. Let me take a second here. Your question is about, is there an financial upside? No, but we know that in any technology play for this particular group, 65 and older, of whom 15% are essentially homebound, another 30% rely on caregivers heavily. This is really about creating partnerships. And yes, the caregivers will be an important part of it, but I don't see how money's flowing as a result of it.
Other questions, comments?
Phil says, we saw a dramatic increase in patient and physician engagement when copays were eliminated. Absolutely, yeah.
They did say with the copays, if you decide to waive the copay, you have to waive it for everybody.
But that means that you will only be receiving 80% of the Medicare allowable rate for this service,
right? Which
means you are essentially taking a 20% discount, but you're counting on like volume over admin.
Yeah. Other questions, comments? I know folks are really excited about the physician director oversight. We have a message from Manzur that this is refreshing. Yeah, I love that was included as a requirement.
Yeah, I mean, I think since nobody's asking questions, I'm so good at filling the airspace. I think that the key here is from that physician side is if there is a physician that is somewhere that needs an uplearn, there are mechanisms for that. ClinX, Aging Here, Combined, whatever it all is. Like there are ways to get that knowledge without having been a CMO first. Okay, there's a question.
John, yes.
Yeah.
Hey, yeah, so I'm John from AIR and then now ClinX. So when speaking about this new access model targeting our Medicare population, you sound like you're speaking to health tech people and impressing upon them the importance of finding a good PC and the various pitfalls related to getting into this access care space. So I was wondering if you can speak a little specifically towards physicians interested in partnering with these startups. I know Amy just mentioned that there's a lot of tools for us to get up to speed with the lingo, including ClinX and Aging Here. But I guess I'm new. This is my first time hearing about Aging Here. Can you tell me a little bit about your company and how it can help me be marketable to companies that are interested in participating in access?
Yeah, thank you for asking that question. So, I mean, I think that the reality is that when you think about people who are 65 and older, it is not just one bucket. You really should be thinking, and this is how I sort of coach up startups and other types of organizations, is that the healthcare system is really divided of 65 plus is really 4 different groups of people, right? 65 plus is not one thing. So you have people who I call them working. They're 65 plus, they are still working, they are functional. Access is a great program for these people. They're still interested in improving their health. They are absolutely intending to lower their blood pressure and improve their diabetes metrics. So that's the working. Then there's the retirees. This is a different group, and I divide them functionally. Like people are, they've got their bucket list, they're visiting the grandkids, they're traveling, they're doing the things that are not related to working, but their health has not really impacted them so very much. Then there's the post-retirement. Post-retirement people are, starting to see their health impact their ability to do the things that they want to do. And then there is the post-retirement, and those are the people for whom their health has become their everyday challenge. A good percentage of them are homebound. And so the Aging Here program basically explores and gives an empowerment to people who are in the startup, the mature business space, as well as people who are interested in the senior serving space, trying to look at things through that lens, understanding how people navigate aging at each of these different stages in their functional decline, and basically looks at the insurance, the caregiving, the what are the things that you're going to have to pay for, and the cost of all of that, and understanding how that ecosystem works and what happens in the post-acute space and sort of in the people's homes at the last mile, specifically their home. That's what I focus on mostly in Aging Here.
Yeah, Amy is an unbelievable expert in like last mile deployment of solutions for seniors. I remember over the years I've had all sorts of silly ideas of what I wanted to sell to or deploy for seniors, and one day she just looked at me and shook her head and she's like, "Get in the car." So she puts me in the car. We drive it over to one of the like rehab centers. She said, "Look, this is who you're."
Are you trying to get them to use an iPhone?
Yeah.
Okay.
Like, what?
You
Like,
do that.
yeah. No, this is not gonna work.
I am the reality checker when, it is interesting, there are so many ideas, and as part of an organization where there's some participants here called Age Tech Connect, and happy to, make sure that everybody here hears about that. But sometimes people make these doodads, like a device, and I'm like, who's going to hook this up in the person's house? I mean, it's a great idea. Like, don't get me wrong. But, there's A, no billing code, and B, nobody to really set it up. And there's a whole ecosystem of people who like set up Amazon Alexas and all these other sort of things, because nobody can really set that up. So I think there will be challenges a la tech literacy with the Access program. And, I spend a lot of time talking about those challenges.
Yeah.
But I don't think there's so much that can be overcome. And I think that if you say it's just too hard, I'm not going to do it, that's not the answer. The answer is, let's see if we can engineer through it.
Yeah. And there are many services, businesses, companies going into seniors' homes already doing other things, so you can potentially piggyback.
Correct.
Right? But you got to know who are the players in that ecosystem? What are they doing? What are their incentives? What are their barriers?
Right.
And that's what
the
Amy-
language. I mean, it's what I have always found, which is really interesting, just to keep building on what John was asking, is that people who have spent almost their entire professional life living in the sort of senior serving space find it really difficult to map how money flows, what Medicare pays for, what Medicare doesn't pay for. And people are often really shocked that, once they need like additional care in the home, that additional care is nowhere to be found unless you have cash. So, it is a problem. Aging in this country is an issue, and that laid on top of sort of some of these new programs, it's just a new opportunity. It's not like a Debbie Downer approach. It's just a new opportunity.
Great. Other folks, other questions, more comments? Reza, Adam. Okay, well, this has been amazing. We'll
send a follow-up.
Yeah, we'll send a follow-up email to everybody with our notes and relevant links. Appreciate everybody's support and being here. We're really excited, and have a great weekend. Thanks, guys.